So, good evening, everyone. I welcome you all to the masterclass organized by Indian Society of Hematology and Blood Transfusion. Our speaker today is a well-known and reputed hematopathologist, Dr. Ruchi Gupta ma'am, who is an additional professor in the Department of Hematology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Today's topic of discussion is lab diagnosis of sickle cell disease. Please feel free to ask any queries. You can write up your queries in the chat box, and at the end of the session, there will be a question answer session where your questions will be asked directly to Ruchi Gupta ma'am. So now I want to invite Dr. Ruchi Gupta ma'am to start today's session.
Hello everyone, and thank you Moshmi for such a kind introduction. Can I start sharing my screen?
Yes, ma'am. Yes.
Okay. So is my screen visible?
Yeah, ma'am, just make it full screen.
Right. It is visible now, Moshmi?
Yes, ma'am. It's okay.
Okay. So, so topic for today's discussion is laboratory diagnosis of sickle cell disease. But before we actually move on to the laboratory aspect of the sickle cell disorder, I'll actually also be touching upon in brief about the origin of the disease and its pathogenesis, because that actually forms an important component when you are dealing with any disorder in the lab. So you really need to know what is the clinical presentation and what all you in that relation, what all you expect to do in the lab and how to interpret the data which is generated by those lab tests. So if you, for people who do not know, the sickle cells were first described way back by Dr. James Herrick in 1910, when he said that he has seen something which was never been described before, and that was sickle-shaped cells in a young male. And then it took almost 2 decades for them to identify, it was Dr. Ingram who identified that the sickle cell is a consequence of the mutation in the beta globin gene. And almost 2 decades later, that is in the 1950s, did it come to be known that it has a autosomal recessive pattern of inheritance and has a carrier state wherein one of the genes is mutated and other is normal, and it can be passed on to the next generation, and you can have a homozygous condition which is broadly known as sickle cell disease or sickle cell anemia. So sickle cell disease is usually used a little more loosely for all those disorders which are co-inherited with sickle cell mutation and result in sickling. Whereas usually we use the word sickle cell anemia for a homozygous sickle cell mutation. And if you look at this disease, it's a global health problem. Though it seems to have arisen in Africa, and it is very, very prevalent in Africa. But then besides the sub-Saharan African region, we have the Mediterranean and the Middle East and the Asia, where also we have people, and a good going load of people who are carriers of this disease. In India, if we look at the prevalence, it is as high as 40% in some of the states, particularly in central India and states like Madhya Pradesh, Orissa, Chhattisgarh, Jharkhand, Gujarat. Here, this is a major health problem. So, this all basic and background information is important when particularly for all hemoglobinopathies, there are some regions in the country where, that is more prevalent. So like sickle, as I said, here in central India and in the southern areas, whereas we have HBE in the eastern areas, eastern parts of the country, and then HBD Punjab is more prevalent in the western side and in Punjab and so on. So when you deal with a patient, the area which the patient belongs to becomes an important component of the history you take, and also from where he has come, and you should know that what kind of hemoglobinopathies are prevalent in those areas. So what is interesting that though sickle cell mutation is typically due to that A to T transition at the beta 6th position of the beta globin gene in the 6th codon basically, but this mutation appears to have arisen spontaneously at least 5 times. And this has been brought forward by studying the different haplotypes by RFLP analysis. And if you look at the different types, we have the Senegal, Benin, Bantu, Cameroon, and Arab Indian. So I know that there might be some people ki ma'am lab diagnosis padhana tha, ye sab kya, what are you discussing? But actually it is important to know that there are different haplotypes. Why? Because the disease severity is dependent upon the haplotype or the kind of mutation which is there in that particular person. Like the Bantu is considered to be a very severe form of the disease, whereas people with the Arab Indian haplotype or the Senegal and the Benin have a relatively milder phenotypes. And this is also possibly due to the presence of a raised HbF level which has been observed in these haplotypes. So this is the basic defect which we have in sickle cell disease. That is, there is a to T transition in codon 6 of the beta globin gene, because of which there is a change in the amino acid from glutamic acid, which is a hydrophilic amino acid at that position. Now that gets replaced by a hydrophobic amino acid, that is the valine. So this is just a diagrammatic representation of the amino acids, and at the 6th position we can see that there is a change from glutamic acid to valine. Sorry. So what happens because of this change? So because of this change inside the RBCs, if you see the hemoglobin molecules, when the cell is oxygenated, the hemoglobin molecules are in a free form. They allow the red cell to be soft, malleable, deformable, and pass through the capillaries. However, the moment it gets deoxygenated, these hemoglobin tetramers, they tend to polymerize, and eventually they reach a stage of nidus formation or nucleation, which subsequently leads to the formation of these polymers. So here, if you can see that the projection and the indentation is depicting the mutated sickle cell, and because of this mutation, there is a tendency of these tetramers to adhere to each other and result in the formation of a polymer. And once this polymer starts to form, then initially it is a reversible phenomena, but subsequently the cells become irreversible sickle cells, which we see on the smear of a patient with sickle cell disease. So there are many factors which can contribute to this sickling besides the hemoglobin concentration, the pH, the temperature. As I initially said that this tetramer which kind of co-polymerize with each other are usually reversed back to their soluble forms once the red cells get oxygenated. But then there is a stage where the critical polymers, or more than 30 tetramers, are they co-aggregate and result in the formation of gelation process, this is known as. And then at this time point, this phenomena of polymerization becomes irreversible. And this phenomena of polymerization is actually the main reason of the presentation and the pathogenesis of this disorder. So as I just said, that the hemoglobin concentration, pH, temperature, ionic strength, any concurrent infections, dehydration, things like these can lead to the precipitation of this hemoglobin S and its subsequent manifestations. So what is the impact of other genetic mutations if there is a co-inheritance? Like if there is a co-inheritance of beta allele which has mutated for sickle, if there is a co-inheritance for HBC, HBD or HBO Arab, this sickling process is facilitated. They have, because of the charge, they tend to co-polymerize, whereas molecules like HbA, A2 and F, they are not really interested in being a part of these polymers. And so if you see, the heterozygous sickles are usually kind of asymptomatic. People who have a co-inheritance of HPFH, or in states where there are mutations where the HbF levels are increased, like in XMN1 polymorphism, this sickling is retarded, and consequently the symptomatology of the patient or the incidence of vaso-occlusive crisis goes down. And there are multiple other genetic as well as non-genetic modifiers which eventually affect the presentation of the disease. Amongst these, the major ones are the Arab Indian haplotype, which I just mentioned. Then in patients who have higher level of HbF, they will have a less severe phenotype. If there is coexisting alpha chain deletion, then again the severity of the disease goes down. Besides these genetic modifiers, there are a number of non-genetic modifiers like infections and dehydration, altitude, smoking, and so on, which predisposes people with sickle cell disorder to have vaso-occlusive crisis. So these patients usually do not come to us, as a workup of part of anemia. Rather, they present more with the complications because of the polymerization inside the cell, which actually leads to a deformation of the red cell. There is a flip-flop of the RBC membrane, and we have exposure of phosphatidylserine serine on the outer side, which leads to a hypercoagulable or a procoagulant state. These cells tend to adhere. There is hypoxia. There is decrease in the nitric oxide. There is vasoconstriction, and so on. And all this unique environment and the unique genetic makeup influences the disease phenotype and is decisive for the clinical severity. And as I just mentioned, so these are the multiple factors which actually contribute to the vaso-occlusive crisis for which these patients actually come to the hospital, and not like any other hemoglobinopathy where anemia is that persistent problem as compared to these painful crises which patients with sickle cell anemia or compound heterozygous sickle beta and so on do face. So if we actually see how it manifests, and it will not manifest at birth because we all know that it takes almost 1 year for the gamma globin chains to go down. So the initial maybe 3 to 4 months are very protective for the child because of the presence of high levels of HbF. However, as subsequently there is a switch from the gamma chains to the beta globin chains, and we have more of HbA. At that time point, because the A is mutated or the gene is mutated and we have a sickle hemoglobin, so these children start becoming symptomatic during the second half of the first year of their life. And at that time point, if you actually see, there will be mild hemolytic anemia which starts becoming apparent by 3 to 6 months of age, and splenomegaly can be noted after 6 months of age. Subsequently, these people will go on to have a state of mild hemolytic anemia continuously throughout their childhood as well as adolescence. This is specifically for patients who are sickle cell disease. So they'll have some degree of anemia, they'll have some degree of reticulocytosis and so on. And then it is a multi-system disorder. They can come to us with, neurological complications, gallstones, asplenia, papillary necrosis, priapism, leg ulcers, and avascular necrosis. So these are in the acute stages, we have acute chest pain and backache. So these patients will have, they'll come to the department for workup of such painful crisis. And when you look at their indices and so on, you will understand that what is basically going on. So let us see if, suppose this is a child I had for workup. He's a 3-year-old child who's a resident of Jharkhand, who's presented with pallor, complaint of abdominal pain on and off. On examination, there is icterus and myasplenomegaly. There is no history of transfusion in the past, and the parents are asymptomatic. So this, I have purposefully added that he is a resident of Jharkhand because this is again giving us a clue as to what are we going to deal with. He looks like a hemolytic anemia, and now he has probably some vaso-occlusive crisis because of which he is having abdominal pain. So if I have to work up these patients in the lab, I'll probably divide this for the purpose of teaching into screening tests, confirmatory tests, and molecular tests. The screening would start with the evaluation of the complete blood counts and peripheral smear examination. Further, if you see what you want to see, that is the presence of those sickle cells, we'll go ahead and do a sickle solubility or a sickling test. And even newborn screening comes as an important part of screening. Further, then, to go on and confirm our findings of the screening, we'll need specific tests which will show us and document the presence of this abnormal hemoglobin, that is by either hemoglobin electrophoresis, HPLC, or capillary electrophoresis. I should have added isoelectric focusing as well. And molecular tests are usually not required for straightforward or clear-cut cases. But yes, we'll discuss where we have the role of molecular analysis. So coming on to screening. So what would the CBC show us? So a patient who is heterozygous, as I have said, that a heterozygous patient is almost always almost asymptomatic. I cannot say always. There can be some acute conditions where these patients also might have sickling crisis. But usually, if you see the heterozygous sickle cell patients are almost asymptomatic. Even their red cell indices, unlike a beta thalassemia trait, are also completely silent, unless you may have some coexisting alpha thalassemia, or you have a coexisting second mutation along with a beta sickle mutation, because of which the patient has presented to you. So if so the second mutation could actually be a change in another amino acid besides the switch from glutamic acid to valine. And because of the second mutation, like the presence of hemoglobin S Antilles or Oman or Jamaica plain, these are personally to me also this is more theoretical, and we are yet to see such cases. But it is known that patients who are heterozygous for sickle cell, if they have some other coexisting mutation, so they will retain their property of, the cells will retain their property to become a sickle. But the electrophoretic mobility of the second result of the second mutation might result in additional band on HPLC and electrophoresis, or it might co-migrate with HBS. So in these conditions, eventually you will have to put up molecular tests to resolve this situation. So I'll bring this forward with an example. Here we have, this was a father of a patient who was getting worked up. So we have a 40-year-old male who was otherwise asymptomatic. His hemoglobin is 12.4 normal. The RBC count appears to be slightly higher. MCV is MCV, MCH, and MCHC are reduced. RDW is almost close to near normal or mildly elevated. There is hardly any reticulocytosis. And if we did an HPLC in this patient because he was getting screened as a part of the screening procedure, here what we can make out is that in the sickle window, the percentage of HBS is 26.9%. Your indices are microcytic hypochromic. So we can start suspecting that there might be a coexisting alpha thalassemia because of which the percentage of sickle has gone down. Actually, the slide probably should have been incorporated a little later when I have already talked about HPLC. But normally I can add on over here itself that normally on HPLC, a heterozygous would have the percentage of sickle to be around 35 to 40%. But in the presence of alpha thalassemia, as we can see from the indices also where we started suspecting that with a microcytic hypochromic picture and a traced RBC count, when I have this in hand that the HBS is also on the lower side, I would suspect that probably there is a co-inheritance of alpha thalassemia or a loss of alpha gene as well. So suppose this is the index case, coming back to the case who was a 3-year-old child with anemia and abdominal pain and so on. So he is anemic. There is almost moderate to severe anemia with a hemoglobin of 7 gram per deciliter. The RBC count is kind of normal, or I would say slightly elevated. And again, here we have some microcytic hypochromic indices. The RDW is high and there is some degree of reticulocytosis. So this indicates that you have an anemia, there is microcytic hypochromic picture, and then there is reticulocytosis. So given in this situation, since we know we are dealing with the case of, we are talking today about sickle cell. So if I look over here, normally what you expect in a patient with homozygous sickle, that the for the given hemoglobin concentration, normally the MCV and MCH are in the normal range. But if it's a heterozygous state with sickle and beta thal, you will have coexisting microcytosis for the same degree of hemoglobin. And that is where your CBC will give you, probably on retrospect, will give you a suggestion that it is not a homozygous sickle, and probably you are dealing with a condition of sickle and with co-mutation of the beta, with co-inheritance of beta thalassemia. And this is how people have shown and how to go about interpreting and correlating the hemoglobin and the MCV values with different genotypes of the sickening syndromes. Like as I said, normally in homozygous sickle, the median hemoglobin is around between 6 to 12. It can be, median could be 8 or 9. And usually the indices even in a homozygous sickle are normal. MCV, MCH, MCHC are silent, meaning thereby that they'll not give you any clue as to what is the underlying disorder unless until you go ahead and do a specific test. Whereas in states like sickle beta 0 or sickle beta plus, the MCV would be reduced. Sickle beta plus would have a relatively better hemoglobin because in the presence of beta plus, some degree of A or the normal adult hemoglobin is also being formed. Then we have SD Punjab, ORF, and conditions like where you have F, which is elevated, like S with HPFH. There, if you see, the median hemoglobin is as high as 13, and the indices are almost silent, and there is no microcytosis. So frankly speaking, when you really see a case who comes to the lab and you look at the indices, you really don't know that it is sickle, then your indices might not give you that much clue. But when you are suspecting, that the child is from Jharkhand and you are suspecting a sickle, if you closely look at these indices, they will give you a clue as to what are you expecting at the genotype level, or what probably would you get when you do an HPLC. So the next thing, naturally, when you've done your CBC, the next thing to do is to look at the peripheral smear, which will show you these characteristic sickle cells, which have basically tapered ends, and these are hyperdense cells, thick at the middle and thin or tapering with tapering ends. And besides these typical sickle, you also have some boat-shaped cells and some, occasional target cells. If the child comes to you with a sickle cell crisis, there would be more reticulocytosis and NRBCs on the smear. And the degree of anisopoikilocytosis is much higher when there is a co-inheritance of beta thalassemia with sickle. That is sickle beta plus or sickle beta 0 will show you more anisopoikilocytosis, and we have a lot of target cells in the smear, which again kind of point towards the presence of a compound heterozygosity rather than a homozygous sickle cell disease. So I am sure that there will be hardly anybody in the audience who has not seen such similar smears, and day in day out we come across these cases. It's just that when you look closely at the smears, you might get a presence of a hobble jolly body, which would indicate that there is some degree of asthenia or hyposthenia. When you see target cells, then you would suspect that probably one of the parents is a beta, and there is a co-inheritance of beta mutation besides the sickle. So once you have seen these sickle cells, it is by default, the next thing would be to do a sickling test. In sickling test, what we are doing is we are producing a hypoxic state for the red blood cells, and by sealing off by either petroleum jelly, paraffin wax, nail varnish, or very frequently we even use DPX in our lab, we can add a reducing agent like sodium metabisulfite, which enhances the sickling. Normally, in a homozygous situation or a compound heterozygous with beta mutation or some other mutation, the homozygotes will show the presence of these sickle cells within an hour, whereas the heterozygotes naturally will take a longer time, up to 12 to maybe even 24 hours. So there can be false negatives because in newborns, naturally the amount of HbF is very high, so that will retard the sickling. And we can have false positive tests when we have some other uncommon mutations where again the hemoglobin molecules can polymerize like hemoglobin settles. Don't ask me, this is theoretical, I have read it, so I put it over here that there can occasionally be false positive results also. So another test which can be put up when you see sickle cells in the peripheral smear is the solubility test. So the principle here is that the hemoglobin S is insoluble in a deoxygenated state in a high molarity phosphate buffer, which contains a reducing agent. So once this HbS is insoluble, it tends to crystallize and refract the light. And subsequently, if you see, this is a sample which is a normal sample which is not showing any turbidity, and you can clearly see the lines behind it. Whereas a patient who's homozygous or compound heterozygous for sickle will show you this kind of turbidity, and those lines behind are not readable. So both these tests have their limitations and some degree of false positivity or false negativity. But overall, if you ask me, there is a good specificity of these tests, specificity as well as accuracy. And it is naturally a requirement to show a positive sickling or solubility test once you suspect a case of sickle cell disease. So now that you are suspecting a sickle cell, you have seen the presence of sickle cells, you need to now confirm that you have this abnormal protein or this mutation which is there in the, sorry, not at the genetic level, but at the protein level. So this is a mixture where you have some alpha, HbA, HbF, and HbA2F, and so on, different chains. So what we can do to separate this is we put them in an electrophoretic field and we tell them to migrate. And based upon their charge, these proteins can migrate at different paces and they tend to separate out. So this was just a diagrammatic representation and a cartoon of the same. This is basically the principle of hemoglobin electrophoresis, where the structural variants that have a change in the charge on the surface will separate out from HbA, A2, and F as they are run on a membrane or a paper or gel in an alkaline media or in an acidic media. The separation is largely but not entirely determined by the electrical charge of the molecule. So when I was a student, this is how it was done in PGI Chandigarh. We used to cast, or I remember madam used to cast the gels on the slide, and using a cover slip, we used to apply the chemolysate, and then a control and the abnormal sample on the samples to be tested were run. And so this is the power source. Here is your buffer tank, which has a cathodal end and an anodal end. And the run of the hemoglobin molecules is basically from cathode to anode, because at alkaline pH, they'll all the molecules would be largely negatively charged. And this is an automated system where you have agarose gels, this has now become much more easier, and this was relatively more labor intensive. So here simultaneously on a gel, you can run multiple samples. Ideally, you should run a control where you have a mixture of abnormal hemoglobins. So when your samples run, you can compare your results with what is coming in comparison to the control. So this is just a schematic representation of what happens when you run a hemolysate on an alkaline pH. So now from this is the cathode and this is the anodal end, you have a faint band of A2, and then major component in a normal healthy individual would be HbA, and just behind HbA we have HbF. But these are the regions where other abnormal hemoglobins can also migrate, like hemoglobin C, E, and O will co-migrate with HbA2. Similarly, sickle, D, G, and leopard migrate in between A2 and F or A. And then you have these alpha gene variants or the fast-moving hemoglobins like K, J, N, IH, and so on, which migrate even more anodal to the hemoglobin A molecule. So this is how you discriminate between a normal sample and an abnormal sample. You need to you need to know what are the normal patterns. You need to have a sample to compare your normal with and your sample with, and so on. And similarly, there is a migration of the hemoglobin molecules differently on an acidic pH. Normally, alkaline pH is more commonly used than the acidic pH. The thickness of the band roughly corresponds to the amount of that particular hemoglobin. So if this was the pattern for a healthy individual, suppose this is the pattern which we are getting for a child who was 6 months requiring blood transfusion. So what we can see is that probably this is a post-transfusion sample. You have some amount of A and majorly F. So if I have a child who is presenting with this pattern, I'm probably dealing with a case of thalassemia major or a patient with homozygous beta thalassemia. If this is the pattern which is coming for maybe a 20-year-old patient who is asymptomatic, I need to know a little more about the history. I need to know the indices, because this is the region where we can have S, D, G, and so on. So the but if you look at it percentage wise, the amount of this abnormal hemoglobin is almost the same as that of the A. So this still could be a heterozygous A, or it could be, sorry, a heterozygous sickle, or it could be a heterozygous D. So, and in this situation, you really need to put up your sickling test. You need to look up at your smear. You need to do sickle solubility and discriminate S and D. Or what you can do is do an HPLC where these two variants are separated out. Again, similarly, we have in the last line, we have a patient who is showing some A2, and your largely you have as D. Your A is absent and you have some degree of F. So this kind of a pattern could come either in homozygous D, because we know that D also migrates with sickle. This could be homozygous sickle. This could even be a sickle with D, and so on. So these are some of the limitations of HP electrophoresis, for which we need to resort to HPLC, where we can discriminate the two. And again, basic simple tests like sickling test will help you to discriminate between a homozygous D or a homozygous S. So back to our case. So suppose this is the HPS hemoglobin electrophoresis of the child of interest, which we discussed, 3-year-old. And so this is the pattern which we are getting on hemoglobin electrophoresis. Now we need to again move on and compare. Since we know that we are dealing with a sickle, so there is currently no confusion that this could be a homozygous D. But still, when we do a confirmatory test further on HPLC, so I'll skip this, like what is already discussed, that this is a semi-quantitative method. It is labor intensive. It does not discriminate all the different types of variants which are commonly there. It will not pick up any coexisting alpha thal. So next, what we need to do is the HPLC. I'll not discuss in detail the principle of HPLC, because this was beautifully discussed by Dr. Reena Das in her last presentation. But briefly, there is a mobile phase where we have different ionic strength buffers, and we also have a stationary phase, which is basically the cartridge through which our sample is injected. The buffer is passed through this cartridge initially the low ionic strength buffer goes on, and subsequently the high ionic strength buffer goes. And based upon the affinity of the particular hemoglobin molecule to this negatively charged cartridge, these buffer ions will gradually push the abnormal variants or the normal variants out from the anodal end, and these will be detected by the UV detector which is there and show the data in the form of a plot. So this is a highly sensitive, specific, quick, but relatively expensive technique as compared to an HB electrophoresis or morphological examination and so on. So before you go ahead and interpret a abnormal graph, you really need to know how a normal HPLC graph looks like, where are the peaks for HBF, where is A0, where is A2, and so on, which I'll not be discussing here because again, as I said, it was already discussed by Professor Reena in her last presentation. So let us see what is my case of interest likely to show. So if we were dealing with a case of heterozygous sickle cell trait, there are some rules which we should know before we interpret our data. So normally in a heterozygous state, the concentration of HbS is usually between 35 to 45% of the total hemoglobin because the rate of synthesis of sickle is also slower as compared to A. The degree of affinity the alpha chains have for the normal beta chains is reduced when there is a mutation of beta S in that beta globin gene. So, and additionally, if there is a coexisting alpha thalassemia, so the normal amount of alpha chains has also gone down. So the amount of alpha chain which will come now combined with these sickle chains is reduced further. And in states with alpha thalassemia, your percentage of HbS will go down. This I showed previously in a case of that elderly gentleman. In a homozygous state, the HbS is likely to be 80 to 90%. In compound heterozygous states, when there is a co-inheritance with beta thalassemia, naturally you'll have to give place for A2, which would be elevated, which will give you a clue that probably you are dealing with coexisting beta mutation. But what we should also remember is that some of the glycated sickle hemoglobin can also, fall in this HbA2 region, and which can result in the elevation of the HbA2. So that this problem then needs to be resorted by parental screening. Further, if we have a compound heterozygous state of sickle with some other structural variant, then since each chain is expected to produce 50% of the hemoglobin, so we'll have 40 to 50% of HbS, and whatever co-inherited is the other structural variant, we'll have 40 to 50% of that particular variant. So this is the HPLC of our patient. Again, I'll repeat the history. The 3-year-old child who's from Jharkhand, anemia and abdominal pain and so on. So what do we see over here? We can see that there is an abnormal peak. The A is lost. The F is elevated to 15.7%. And the A2 concentration is also higher than expected. Normally, anything above 4 is considered suspicious for presence of beta thalassemia trait, or rather not suspicious, rather anything above 4 is kind of given diagnostic for the presence of co-inheritance of beta thalassemia. But we should be careful because in sickle, as I just said, this A2 might be elevated because of the abnormal glycated HbS, which can also fall back in this area. So what to do now? So what we can understand is that there is no adult A, and we have almost 74% or 75% of this abnormal peak, which is likely to be due to sickle. So before you jump to a molecule mutation to resolve this issue, the best and the simplest answer is to say that do a parental screening. The parental screening will tell you what possible genotype is there which has resulted in this plot. There can be a co-inheritance with beta. There could be sickle homozygous. Besides homozygous sickle, you can have SC, SD Punjab, S Antilis, basically a compound heterozygous states for so many different hemoglobins which can clinically present as a sickle cell disease. So HPLC is otherwise a good diagnostic technique or a test which can help you to resort and understand what is co-inherited with sickle cell, and that can also easily be addressed by doing a parental screening. So this is the HPLC plot of the father. Here we have a good going hemoglobin of 13.1 gram per deciliter. The indices are on the lower side. You have microcytic hyperchromic anemia and a raised RBC count. So this is speaking for itself. When you do an HPLC, you have a A2 which is raised to 4.6%. So the father is probably heterozygous for beta thalassemia. Whereas if you look at the mother has an S window of 36.2. The A2 is normal, F is 2.4. Even indices wise, she doesn't really seem to be giving away anything as to what could be going on. So this is basically the mother is a heterozygous HbS, whereas father is a heterozygous beta thalassemia. And so it is easier now to conclude that probably the child is a compound heterozygous sickle beta thalassemia. Besides HPLC, we can also resort to capillary zone electrophoresis, which is also a good diagnostic modality to identify the abnormal hemoglobins. Again, here you have a strong endoosmotic flow of cations towards the cathode, which pulls the sample, which pulls all the abnormal peaks over here. There is a detector which will result and give you a graph and show you the separation of the different types of hemoglobin molecules. Here the results are divided into different zones like zone 1 to zone 50, and this is classic this is a normal plot where you have HbA and HbA2. The different zones have their own labels, and if you bring your cursor to that particular zone, it gives you a drop down window and tells you that what all different variants can be present in that particular zone. For example, we have HbE in zone 4 and so on. So if we go ahead and see the different patterns which can be obtained by capillary zone electrophoresis. Again, here we have a F in the zone 7. Then we have a zone for HBS. We have a zone for HBC. Here, one of the very good advantages of this system is that it gives you a discrimination between A2 and E, because both A2 and E are eluted in different zones, as you can see over here. So this is zone 3 for A2 and zone 4 for HBE. Plus, this is also a very sensitive technique where co-inheritance of alpha thalassemia, or basically it is a good system to pick up. Alpha thalassemia, HB baths, is readily identified and picked up by capillary zone electrophoresis as compared to a biorad variant 2 or an HPLC analyzer, which has relatively lower sensitivity for alpha thalassemia. So the final diagnosis in our case is a compound heterozygous sickle beta with co-inheritance of beta 0 thalassemia. So why beta 0 thalassemia? Because there is no A. The coexistence of beta has been documented by screening the parents, but otherwise also which we had, the points which we had in favor was there were microcytic indices, the A2 was raised, and the parental screening kind of clinched the diagnosis. Since this co-inheritance is very common when you start seeing patients with sickle cell disease, I'll just spend a few minutes on what is the impact of co-inheritance of beta thalassemia with sickle cell. So there can be a beta 0 state or there can be a beta plus. These 0 and plus kind of indicate that whether there is almost no production of the normal beta chains or there is some production of the beta chains. So in a state where we have beta 0, there will be no hemoglobin A. The HbS within the red cells will decrease. The percentage of HbA2 and F will increase. And this lessens the likelihood of sickling and also lessens the degree of hemolysis. Similarly, in patients with sickle with beta plus thalassemia, you will have some variable amount of HbA, but naturally the major component would be sickle and your A would be less than 50%, which would give you a clue that you are probably dealing with a sickle beta thalassemia. So though the severity of the disease decreases, but the frequency and the incidence of painful crisis does not really go down to that degree. And in patients, because the hemoglobin concentration improves, it is said that complications like retinopathy are higher in these patients. This is again a diagrammatic representation, or rather, these are the HPLC plots. Sorry, from the net and from our Barbara Bain, where you can see that this is a HPLC of a patient where there is co-inheritance with ORA. This is just to show that when you have a co-inheritance of other structural variants, the amount of sickle as well as the amount of that structural variant is close to 40 to 50%, and this is how you can discriminate or identify the abnormal variants. So let us see what more can we do for this family. Suppose that the mother is now pregnant and has conceived. So what do you think should be the role of the pathologist in this situation? There is a very important role of antenatal testing in patients of either homozygous or compound heterozygous states of sickle cell. And here you will largely have to rely on the molecular tests to guide the patient whether now is she carrying a patient with sickle cell disease or not. And this can be sorted out by doing either amniocentesis, or we can do chorionic sampling as early as 8 to 10 weeks of gestation. And Professor Reena is doing excellent work on cell-free DNA, and fetal cells can be collected from the maternal circulation, and the presence of the mutation can be identified even in those fetal cells, and accordingly the patient can be counseled and advised as to whether she should carry on with the pregnancy or she should not. The commonly employed molecular tests are RSLP, ARMS PCR, or allele-specific oligonucleotide hybridization, and so on. Another important aspect of sickle cell is newborn screening. India alone contributes to almost 15% of the world's sickle cell anemia neonates. So I think that it is definitely a pertinent problem and a point where we can, we should introduce newborn screening. And so if you look at what tests can be used for newborn screening, HPLC, IFE, sorry, this should have been isoelectric focusing, and capillary zone electrophoresis. All these tests are recommended for, all these technologies are sufficient to identify the presence of abnormal sickle hemoglobin, and these are the graphs of HPLC as well as capillary zone electrophoresis. As you can see that in a newborn, the hemoglobin is largely made up of HbF, but when the child is carrying is positive for sickle cell, then up to 4 to 5% of a small peak can be detected even in newborns. Though by this technique we can pick up that there is presence of sickle hemoglobin, but this might not be sufficient enough to identify whether it is a compound heterozygous state or a homozygous state. So to confirm that, you can repeat this run when the child is a little older. And similarly, in capillary zonal electrophoresis, largely you have F, then you have small amount of A, and again a small amount of S, which is telling you that the newborn is affected by sickle cell disease. This is a beautiful work done by Professor Roshan Kola and her team, where they screened newborns for the presence of sickle cell disease in tribal population in the state of Gujarat and Madhya Pradesh. For over a period of 6 years. Almost 9,000 newborn babies were screened, and again the screening was largely done by HPLC, and molecular analysis was done in a subset. 128 patients were found to be positive for sickle cell disease, of which 69 were homozygous, whereas 18 showed a compound heterozygosity for beta thalassemia. Acute painful events, severe anemia, fever with infections were the major complications, and 23 of these babies required hospitalization. They were able to do a counseling for a majority of the individuals who had these children, and the parents were educated and counseled for home care as to how to go about manage these painful crisis time and again. So newborn screening, even in a country like India, is a very important aspect of this disorder, and probably should be taken up as a, in other states as well, to reduce the birth of these children with either sickle cell disease or sickle beta. So when I did a literature search as to what is new in the diagnosis of, sickle cell disease, so I came across this article which had some very new tests according to me, but they are actually not really new. There was an image process. They have devised some image processing techniques where these sickle cells can be identified. Then there is an imaging flow cytometry assay and a software algorithm to identify those sickle cells. Then you have a lateral flow immunoassay, also known as sickle scan. This is almost like a pregnancy test where the cartridge is coated with monoclonal antibodies against HBS, HBA, HBC, and so on. And when you put a drop of blood and passes through the cartridge, it will give you a band if the particular abnormal variant is there. So it seemed like a very good test for screening populations. Then there were tests which were based on the density-based separation of the abnormal hemoglobin and paper-based hemoglobin solubility tests. So anybody who is interested can refer to this article for reading up these tests in detail. And I believe these are probably more in use or in practice where the prevalence of sickle cell disorder is high, and you are usually screening, larger populations or individuals for the presence of this hemoglobin. So to conclude, sickle cell disease is actually a multi-system disease and not a typical hemolytic anemia as we should think about it. The diagnosis does not require, very high-end tests. And there are numerous genetic as well as non-genetic modifiers which affect the clinical presentation. So you will have patients coming to you at different ages with different type of clinical presentation. A combination of morphology with HPLC of HP electrophoresis has reasonable diagnostic sensitivity and specificity. It's only in controversial cases, as I mentioned, that there are some other hemoglobins like hemoglobin S. antilis, C. Harlem, etc., which can also show presence of sickling. And there you might have to resort to molecular tests to confirm that it is another abnormal hemoglobin. Otherwise, molecular tests are more restricted for use in antenatal testing and counseling of the patients. So this is our team in the department here at SCPGI. We are a joint department with both clinical and the lab arms. And here this is Aslam, who's actually helping to run these samples. And we are thankful to National Health Mission India, which have sanctioned a thalassemia screening program at our center, which has helped us to offer these services to people who are coming in our OPD or from people from the nearby region. So thank you, and I'll be happy to take any questions.
Thank you, ma'am, for a wonderful session and in a concise manner. Almost all the aspects were discussed with intricate details. There are not much questions left, but from my side, actually, I wanted to ask a few things. Like in one slide, you discussed that when there is a heterozygosity with the sickle, double heterozygosity with the sickle, and the mean hemoglobin values which can come. So in many a time, there was the hemoglobin values with double heterozygosity were varying from 11 to 13 even. So why to do HPLC in that case? How we can pick up what will be the presentation of that patients? We will miss out those patients mostly.
Right. So, Mostly, frankly, if you ask me, this part of teaching the role of indices in a case of sickle is because when you look at it, you actually see and appreciate कि अच्छा ऐसा होता है. But frankly, if you ask me, my personal opinion is that these people are actually, in terms of CBC, they are very silent. You will never be able to identify a homozygous sickle who's never had a painful crisis, of maybe a female who's having a hemoglobin of 8, 9, or 10, and it might be messed out, on unless and until this patient has had some episode of, hemolysis or jaundice or a painful crisis, because of which then these patients come forward for screening, and then you realize that, okay, that this is actually a case of homozygous sickle. Right? So yeah, that is my opinion. And even for a heterozygous state, so I think, unless until you do an HPLC, शायद कभी पता नहीं चलेगा that that person is actually a carrier for sickle, right? जैसे at least beta thalassemia में we get a clue कि microcytic hyperchromic indices है, RBC count raised है, and so on. A heterozygous sickle तो मतलब बिल्कुल ही silent रहता है.
Okay. And ma'am, with the advent of HPLC and other methods, is there really any role in which setup we are still doing electrophoresis? And if we want to do electrophoresis, shall we do both the alkaline method along with the acidic method? Because there are many overlap with the sickle.
Right. So as it is being taught that whenever you have an abnormal hemoglobin, you should document its presence by at least 2 different mechanisms. So one is that suppose in a homozygous state, if you have a peak in the HPLC, it might be worthwhile either to do a sickling test or a sickle solubility test, or in centers where they are still doing HB electrophoresis, if you run it on the gel and show that yes, it is coming in the SDG region. But even in our center, and we are now mostly doing HPLC, and electrophoresis is done at very, very few places to sort out, to reach a diagnosis of sickle cell. Because I think jitne bhi और people, students who have passed out from here, and majority of the people have either D10 or they have variant 2. So that has now become more of a routine test mechanism rather than HB electrophoresis. But yes, even HB electrophoresis, if you see, it is relatively cost effective as compared to HPLC. So जहाँ पर नहीं है HPLC, वहाँ पर you can still go ahead and do.
And why HB-CZD is more sensitive in picking up alpha thal? You are telling that it is more sensitive to pick up alpha thal than the HPLC itself.
Probably उसमें जो capillary है ना, and the way they are able to show 15 different zones. If you see in HPLC, the 6 minutes run में there's a chance that कोई abnormal variant जो है वो नहीं pick up हो पाएगा. But however, in capillary zone, because probably of their of the run and those donations, जो abnormal peaks हैं, they are getting kind of resoluted. वो migration जो उनमें जरा सा difference है, that is getting picked up by capillary zone as which is not getting picked up that easily by a HPLC. So if you see, this is the same principle in isoelectric focusing. Even isoelectric focusing is like HB electrophoresis, but it's with a more finer resolution. So जो bands overlap करते हैं HB electrophoresis में, वो isoelectric focusing में resolve हो जाते हैं, and you can identify G and S and D separately as compared to what you can identify on a alkaline gel electrophoresis.
And so, ma'am, wherever we get a HBS percentage just more than 25 but just below 30, we should always do for a HB alpha screening. So in those cases, we should go.
Right. We should screen for the presence of alpha thalassemia, and so because and if you go through that paper जो अभी दिखाया newborn screening वाला, हम करते नहीं है, but when they have done their newborn screening, they have I think showed almost that 70% or 60% of their patients with sickle cell disease had an alpha thalassemia. And because इतना ज़्यादा proportion high है in Indian population की आपका Arab Indian haplotype है, F ज़्यादा रहता है, and probably because there is so much co-inheritance of alpha thalassemia, इसीलिए painful crisis and VODs are relatively less in our subcontinent. It's just that we don't probably screen all these patients for alpha thalassemia, इसीलिए हम पकड़ते नहीं हैं. But that is a clue on which you should probably go ahead and screen.
Yes, and ma'am, when there is a coexistence of sickle beta, so when we are taking, normally we are taking more than 3.5 to more than 4%. For you have already discussed it, but still I want to ask, in those cases which are having marginal A2 with sickle cell, so in all the cases we should go for a parental screening first, and then we should release our report.
Yes, I would advise that. Or if you want to release a report, you can always say that a possibility of a compound heterozygous state cannot be ruled out. Though, in fact, I was showing to Dinesh that in Barbara Bain, जो उन्होंने run दिखा रखा है heterozygous sickle cell का, उसमें उनका A2 is 5.1, 4.6, उसको भी उन्होंने heterozygous sickle ही लिखा हुआ है. So I was wondering that the percentage of adduct can go up to that high. But so before you say or you think that it is a compound heterozygous, it would be worthwhile to screen the parents.
And also, ma'am, you told that NCV and NCH in the NCV can be helpful because when there is a coexisting beta, the NCV will be low.
Will be low. But मुझे क्या लगता है ना Maushmi, because of the reticulocytosis and maybe if the patient has had received any transfusion, तो शायद आप खाली predict ही कर सकते हो, या आप when you see the smear and you see target cells and things, you will just say कि probably ये sickle beta निकलेगा, but you will actually have to go ahead and confirm it whether it is sickle beta or it is homozygous sickle.
Okay, ma'am. Thank you.
Like a personal tuition I am taking with you.
No, ma'am. There are many actually. Thank you, ma'am, for answering all the questions. And I will. Can I just end the meeting here with the both of
them? Thank you, Ruchi ma'am. Thank you, Maushmi ma'am. Thank you, ma'am. Bye. I'm ending.
Okay.
Right.
Thank you.
Okay.
Thank you.
Bye. Thank you.